Hello and welcome. I'm Dr. David Minter, and this is Internal Medicine, where we talk about internal medicine topics and we talk about emergency medicine topics. Today we're going over some basic EKG interpretation skills. Now, this is something that people probably bug me about 50 times a year, that I have to sit down with somebody and go over basic skills about how to interpret EKGs. So some of the tips I've learned over the years is it's best to have a system with this. It's going to be very slow at first to interpret an EKG, but over time you get more confident with it and thus you get faster at it. So the end goal being that you can just glance at an EKG for a few seconds and be able to make an interpretation. But to do that, we need some fundamental skills. So the system that I've set up is rate, rhythm, axis, interval, hypertrophy, and then any miscellaneous information, things that didn't really fit into the fundamental points I listed earlier. We can do a whole separate video sometime about miscellaneous things to look for, but right now we're just going to focus on the rate, rhythm, axis, interval, and hypertrophy. There'll be a practice EKG that I'll flash up at the beginning that you can try to interpret, and then we'll go over what the answers are at the end.
What is your interpretation?
So as I stated, one of the main things you're going to need is a system for interpreting EKG. So today it's going to be rate, rhythm, axis, interval, hypertrophy, and ischemia. Like I said, we can talk about miscellaneous all in depth in another video if you like. So let's look at a real basic EKG to start with. I'll give you a hint, there's really nothing abnormal that's in this. This is a normal sinus rhythm EKG, but we're going to be able to articulate by the end of this video about exactly what's so normal about it in a speedy process where you can sound like you really know what you're talking about. So initially, we're going to have to do some background about EKGs, about cardiac impulse formation, just to kind of understand some of the nomenclature that goes along with it. Believe me, it'll be brief, and then we'll focus on interpretation skills. So to start with, there's the sinoatrial node, which is where impulse generation happens. This is in the right atria. It travels, this impulse goes down the AV node where conduction is slowed between the atria and ventricles. It travels down the right bundle branch and then the left bundle branch, which has two different parts. And we can talk about these parts a little bit more when we talk about bundle branch blocks. When we talk about what shows up on the piece of paper with an EKG, we're going to look at, there's a P wave, there's a QRS complex, there's an ST segment, T wave, and a U wave. And each of these have different representations for what is happening in the heart, as well as pathology that happens with delays into these intervals. Starting with a P wave, this is the atrial depolarization. The first half of this upstroke in most of the leads represents the right atria, and the second half of it represents the left atria. This is, like I said, initiated by the SA node. The PR interval is the impulse traveling from the atria to the ventricle. Via the AV node, there's a QRS segment, which is the impulse traveling through the ventricles via the His bundle Purkinje system and represents rapid depolarization. There's ST segment that represents ventricular repolarization, and then there's a QT interval that represents ventricular depolarization and repolarization, since it combines the QRS segment, the ST segment, and the T wave. The T wave is the rapid ventricular repolarization. And then in some EKGs, you may notice a U wave. Sometimes this can be pathological or it can represent the His Purkinje system repolarization. Just talking about electrode placement for EKGs, they're typically placed on the right arm and the left arm, represented by RA and LA, as well as the left leg. And then there's a fourth electrode that's placed on the right leg, which acts as a ground. EKG records the voltage difference between these specific pairs of electrodes. So for example, there's the limb leads, which are 1, 2, 3, AVR, AVL, and AVF. They view the heart in a vertical plane. There's the bipolar leads, which are 1, 2, and 3, which measures the difference between electrodes. And then there's the augmented leads. That's what that A stood for, in case you never knew, which is AVR, AVL, and AVF, which measures electrical potential at one electrode relative to the average of the other two limb electrodes. And then there's precordial leads, which is V1 through V6, which views the heart in a horizontal plane. The direction of the deflection on an electrocardiogram depends whether the electrical impulse is traveling toward or away from the detecting electrode. A downward deflection occurs when the impulse is moving away from the lead, and upward, or a positive deflection, occurs when the impulse is moving toward the electrode. So lead 2 typically aligns with the overall electrical axis of the heart, making it a prominent for rhythm analysis. AVR often shows opposite polarity to the main cardiac vector. AVR shows opposite polarity of the main cardiac vector, so meaning that this is going to be a right-sided lead like V1. So this is going to take on a lot of the opposite direction of the rest of the heart, since V1 and AVR are both right-sided leads. Talking about the paper and how this is recorded, the recording travels at 25 millimeters per second. There's one small square, which is 1 millimeter, which represents 0.04 seconds, which is 40 milliseconds. A large box, which is 5 small squares, represents 0.2 seconds or 200 milliseconds. As far as the electrical activity, which is detected by the electrocardiogram, it's measured in millivolts. Millivolts is represented by 1 centimeter upward deflection. So 0.1 millivolts equals 1 millimeter, which is also equal to 1 small square. So that way, when we talk about intervals, we're all up on the same page for what the duration is and how that can be represented visually on an EKG, as well as talked about in seconds and milliseconds. So let's talk about rate first. A normal rate is between 60 to 100 beats per minute. Bradycardia is represented by less than 60 beats per minute, and greater than 100 beats represents tachycardia. There's a couple of different methods for calculating rate on an EKG. You can look between large boxes, where if they're one large box apart, that represents 300 beats per minute. 2 large boxes apart represents 150 beats per minute, then 100, 75, 60, 50, and so on. The problem with using this method for rate determination is that if there's a variation between beats, then you're getting an inaccurate measurement because you're only representing the heart rate that's between the 2 QRS intervals that you're looking at. So if you have atrial fib, atrial flutter, or anything that has irregularity, then this is not going to be a very appropriate method to get an accurate count of rate. Another method we can use is counting the amount of QRS segments that we see, how many depolarizations that there are, and then timesing this by 6. So since it's a 10-second strip, so if there's 10 R waves that are present on the strip, you times that by 6, and then you get 60 beats per minute. So this is a lot more precise and can also be used for irregular heartbeats. So let's look at this for example. We'll take a 10-second strip that's present in lead 2. Lead 2 is the most common lead that gets printed on EKG when they want to give you a telemetry strip. So a close-up representation, we can see that there's 12 QRS segments that we count. We times this by 6, and then we get a pretty accurate view of the heart rate, which is 72, which is pretty close to what the computer calculated. If you wanted to use the box method, we can see that the R waves are 4 large boxes apart. So this would represent 75 beats per minute. Next, let's talk about rhythm. So when discussing rhythm, we want to decide, is this a sinus rhythm? Is the rhythm regular? So you want to examine a rhythm strip. Lead 2, like I said, is the most common one that gets printed out at the bottom of an EKG. Some characteristics of sinus rhythm would be a regular, uniform P to P interval, as well as a regular uniform R to R interval. There's going to be a uniform P wave that's going to be before each QRS segment, with upright P waves being in leads 1 and 2 with a consistent PR interval. So these are all things that scream normal sinus rhythm. There's a couple different ways to do this. Taking a scratch piece of paper and just measuring out each QRS, measuring it out once on a piece of paper, and then representing each QRS segment and looking down to make sure that the whole strip is regular. Another thing to do would be invest in a pair of calipers. I have several pair. I hand them out throughout the year when I'm talking to medical students and residents too, just because they've saved me a lot of trouble at maybe misidentifying an arrhythmia. Some cardinal features of what would be a normal sinus rhythm would be narrow complex, a regular rhythm, like I said, uniform P waves before each QRS segment, the P waves upright in leads 1, 2, also AVF. A lot of times it's biphasic in V1, and then a consistent PR interval, and then the heart rate being normal between 60 and 99 beats per minute. So these are all features of a normal sinus rhythm. So let's take an EKG, for example. So is this a sinus rhythm? Well, just visually inspecting it by stepping back, you can see that there is irregularity that's present. So the 3rd, 4th, and 5th beats that are also present in the rhythm strip that's at the bottom, they look like a regular uniform P to P interval, regular R to R interval. They look like the same PR interval. They're narrow complex. The P wave is upright in 2. So this beat itself, this set of beats all look sinus, but then you'll see regularity created where there's a delay. And then there's an QRS segment, and then there's that same P to R interval and that same couple of beats, which all look sinusy, and then followed by a delay. So this is just an example of what is a sinus arrhythmia. So it's a sinus beats are happening, but there's an irregularity to it, but the irregularity is happening at the same pattern. Next, let's talk about access. So there's multiple different electrodes that are present in the limb leads that all give a vector direction. So starting with lead 1, we can see that this is flat, so this is 0 degrees. We have lead 2, which we can see this is in the positive interval, which is plus 60. We have lead 3, which is plus 120 degrees. And then on top of that, we can map the augmented lead, starting with AVF, which has a vector of plus 90, AVL, which has a vector of negative 30, and then AVR, which has a negative vector of 150. So together, the normal axis that we would see on a patient would be between negative 30 to 90 degrees, which can be represented by this area. So it's really just AVL to AVF. We have a left axis deviation, which is negative 30 to negative 90, and then a right axis deviation, which is 90 to 180. So overlaying this, the heart, you can see that when it's beating, that this vector is going to be mostly to lead 2, which is going to have a mostly positive upward deflection. So if we look at this with the cameras that are in mind, this is the direction that the heart is being viewed upon by each one of these limb leads. So we can see that once we post what the electrodes are seeing at each one of these limb leads, we can see the change in positive deflections. So the most positive, meaning an upright segment, is lead 2, because the QRS, there's almost no down segment that's there. It's almost all positive, and similar to AVF in this case. And this is an EKG from a normal 26-year-old. Whereas AVR, it's very negative, the deflection. Next, looking at the precordial leads, we can see their place where V1 is on the right side of the chest, and then everything else is kind of wrapping around it in that horizontal plane. So starting with V1, you can see the directional vector is to the right side of the heart, and then V2, 3, 4, 5, and 6 wraps around the side of the heart, or the bisected heart that's present on the image. So again, when we examine a little bit closer, and then we see the lead deflections, we can see in AVR, this is mostly a negative deflection. And then by V2, 3, 4, 5, and 6, it gradually becomes more of a positive upward deflection. This is also known as R wave progression. So R wave progression means that there's a small R wave in lead 1 that becomes larger than the S wave by lead 4, with a small S wave that's present in lead 6. So sometimes you'll hear ER doctors refer to poor R wave progression on EKG. It's an inconclusive abnormality. Sometimes it represents an old MI, branch blocks. It can represent left ventricular hypertrophy or right ventricular hypertrophy. When determining access, there's a couple of different methods to do this, so I'll go over 3 of them real quick. So method 1 is the most accurate, which is choosing a limb lead that's closest to being equiphasic, meaning that there's as much of an upward deflection as there is a downward deflection. And the axis about this lies 90 degrees to the right or left of this lead. So the problem with this method is that you really have to have that previous map that I just showed you about the limb leads and memorizing which vector goes with each of them. So that can be a little bit cumbersome. So luckily there's a couple of easier ways to do this. Method 2 is examining leads 1, 2, and 3, where normal axis you're going to have upright in 1 and 2, and then it could be either by lead 3. And then there's more specific diagnosis that goes into normal left and right axis. The next one, which is the easiest one, is the thumb method. That's what I advocate for because it's very easy to remember. So you take a normal EKG and you look in lead 1 and AVF. So you imagine your left hand is lead 1 and your right hand is AVF. If both your thumbs are pointing up, then this means that the axis is normal. So thumbs up with your left hand, thumbs up with your right hand, great. Then that's normal axis. Hooray, both your thumbs are up. If one thumb is up and the other is down, the axis is deviated in the direction that thumb is up. So hypothetically, if AVF was down right now, my right thumb would go down, my left hand would still say thumbs up. So my left hand is the right axis, left axis deviation. Differential for axis deviation, right axis deviation and left axis deviation will both be normal variance. Right axis deviation can be a child or infant too, since they have more abundant right ventricle. It can be from pulmonary conditions causing pulmonary hypertension, cor pulmonale causing right-sided heart strain, so things like COPD. A new onset acute pulmonary embolism can cause right axis deviation. Usually it would be like a saddle PE, not just a normal PE. Cardiac causes of this, anything that causes right ventricular hypertrophy, so congenital causes like pulmonary stenosis, tetralogy of Fallot, Epstein's anomaly, transposition of the great vessels. We can get lateral MIs, right bundle branch blocks, atrial septal defects, dextrocardia. Can all cause right axis deviation. Arrhythmias, VTAC, depending on the origin of the rhythm, can cause right axis deviation. It can also cause left axis deviation and hyperkalemia. Some unique things to left axis deviation would be bundle branch blocks, like left bundle branch block or left anterior fascicular blocks. Structural heart disease, now we're talking about an inferior wall MI might cause left axis deviation, but things like LVH and then all the conditions that lead to LVH, which is generally cardiomyopathies. Some congenital causes like ventricular septal defects, and then other things that stress out the left ventricle, which would be aortic stenosis, mitral regurgitation, also mitral stenosis. So starting with the PR interval, this visually maps out to about 3 to 5 boxes, which is equivalent to 120 milliseconds to 200 milliseconds. If the PR interval is longer than that, then we consider AV blocks as a possible etiology. Short PR intervals are sometimes consistent with Wolff-Parkinson-White, as well as Lewontin-Ganong-Levine syndrome. Okay, next let's talk about the QRS interval. So visually this can be seen at less than 3 boxes, which maps out to around 100 to 120 milliseconds. This represents an interventricular conduction delay. The two major ones to look for would be left bundle branch blocks and right bundle branch blocks. Starting with right bundle branch blocks, we can see that there's a wide QRS. Major identification to make from this would be looking in V1 to look for that rabbit ear appearance where you see an RSR pattern, or possibly a small r, small s, and a large R, two large R patterns that are there. And it takes a little bit of time. I recommend looking through as many EKGs as you can until you get comfortable recognizing a right bundle branch block, because you're going to see them quite regularly. The differential for somebody having a right bundle branch block would be right heart strain problems. So things like pulmonary hypertension, OSA, cor pulmonale, COPD, again, acute pulmonary embolism, possibly ischemia, and then atrial septal defects. Moving on to left bundle branch blocks, the place you're going to want to look for this would be in V6 and look for that characteristic monophasic slurred or notched R wave in appearance. You can see this in V5 and V6, sometimes one in AVL. There'll be some characteristic ST segment changes with this, as left bundle branch blocks are common masqueraders for ischemia. So again, look as many EKGs as you can about left bundle branch blocks until you feel comfortable being able to identify them. Things that cause left bundle branch blocks would be things like chronic hypertension, valvular disease, ischemia, cardiomyopathy, things like myocarditis, congenital heart defects, all things that put strain on the left side of the heart. So if your QRS is not greater than 120, if it's between 100 and 120 with these characteristic rabbit ears or slurred notched R wave in V6, if it's between 100 and 120, this can be possibly an incomplete left bundle branch block or an incomplete right bundle branch block. Next, moving on to the QT interval. This one's a little bit more complicated. There's a sex difference between what is a normal QT interval, where 460 is for milliseconds is for females, greater than 450 is greater for males. But there's the major complication that happens from QT prolongation is torsades, which is polymorphic VTAC, and that happens at greater than 500 milliseconds. QT interval is naturally corrected for rate. So there's a formula, Bezet's equation, which is the QTC divided by the square root of the R to R interval. This isn't something you're going to need to calculate. This EKGs do this for you. So when you look at an EKG readout, it will have a QT interval and then have a slash QTC for the corrected one, because it did the math for you. No one's going to expect you to do square roots in your head. Short QT intervals can be caused by things like hypercalcemia as well as digitalis effects. And then there's short QT syndrome, which is rare electrical abnormality characterized by the presence of ventricular tachyarrhythmias leading to syncope and sudden cardiac death. So if somebody had a syncopal episode, this would be something for sure to screen them for short QT. And this would be a QTC measuring less than 340 milliseconds. So because of this has to be corrected with math, there's sex-based differences. It's hard to glean what is a visually normal QT interval. To quickly glance at an EKG and decide that this is less than half of the less than half of the R to R interval. So you can see visually here that this QT is long, representing that it's greater than half of the R to R interval. So this would be a good screening test for you if you were to glance at an EKG or a telemetry strip to decide if somebody has a long QT or not. There are lots of stuff that causes long QT. antiarrhythmic medications, as well as lots of antibiotics and antifungal medications, antipsychotic medications, opiates, including methadone and tramadol, electrolyte abnormalities more on the low end, hypokalemia, hypocalcemia, hypomagnesemia. There's congenital causes of prolonged QT, things like Jervell and Lang-Nielsen syndrome. Romano-Ward is another genetic syndrome that can do this. And then there's some medical problems that can do this, like subarachnoid hemorrhage, myxedema, as well as ischemic heart disease. Now let's do hypertrophy. Starting with the atria, right atrial hypertrophy, or P pulmonale, is represented by having a tall P wave in lead 2, 3, and or AVF being greater than 2.5 millimeters. Left atrial hypertrophy, you can see with a biphasic P wave in V1, where the negative deflection is greater than 1 millimeter or 1 box, because it's not unusual to have a biphasic P wave in V1, but if it drops down the second half of it, where it's greater than 1 millimeter, then that can be possibly due to left atrial hypertrophy. Ventricular hypertrophy, you can have both right and left. Starting with right ventricular hypertrophy, this is much more uncommon to find in an adult. They'll have a right axis greater than 110 degrees. There'll be a prominent, or in V1, there'll be a dominant R wave, which is greater than 7 millimeters. So this is going to have, another way of saying this would be early R wave transition, where there's a prominent R wave that starts off immediately, as opposed to that normal R wave progression we talked about earlier. And then in lead 6, the S wave is going to be larger than the R wave and is greater than 7 millimeters. So here we can see an example of a patient that I've had that had congenital heart disease and has a wide QRS, so he's got an interventricular conduction delay, but you can see that there's a pretty prominent R wave that's already present, which is way greater than 7 millimeters in V1. For left ventricular hypertrophy, there's the Sokolow-Lyon criteria. The Sokolow-Lyon criteria dictates that you need an S wave in V1 plus an R wave in V5 or V6, whichever one's bigger. If you add up the two of them, that they're greater than 35 millimeters. Another way of visually looking at this is that there's an R wave in AVL that's greater than 11 millimeters. So you don't need to have both of them, but if you have either one of those by the Sokolow-Lyon criteria, you have LVH. And there's a bunch of other criteria that are out there to determine left ventricular hypertrophy. This is just the most common rule I see applied. So you can see in this depiction that there's the S wave in V1 is almost 30 millimeters on its own, and the R wave in V5, which is bigger than the one that's in V6, is almost 40. So some of those is 70. So this is a very obvious example of left ventricular hypertrophy. Now let's talk about ischemia. Ischemia can be denoted based on timing of when ischemia occurred. There's hyperacute T waves can be seen within 5 to 30 minutes of having ischemic damage. ST segment elevation is usually in the first few hours. This can also be accompanied by reciprocal ST depression. Then over the course of time, Q waves develop. This indicates hours to days after an MI has happened, and then you'll see resolution of the ST segment changes several days afterward, and then old changes can be things like T wave inversion. So represented here visually is what denotes the baseline, which is the line that kind of connects from the previous T wave to the new P wave. That's the isoelectric point, and then you see a significant decline in that, representing ST depression. ST segment elevation is a little bit more complicated because it changes based on leads. So greater than 1 millimeter in 2 contiguous leads, other than V2 and V3, is what indicates ST segment elevation. V2 and V3 have some different rules for them. Again, you don't necessarily have to have them memorized off the top of your head, depending on what you're going into, but at least having a reference for this to be able to look up to see is like, hey, that looks a little bit elevated in V1 and V2, but is it enough? Just always know that there's a little asterisk in your head that those leads have different criteria for them. When we talk about contiguous leads, we're talking about leads that represent adjoining areas of myocardial tissue. So visually, we look at 1 in AVL, that representing like anterior lateral wall MIs, 2, 3 in AVF, things like that representing inferior wall MIs. So let's put this all together now. This is our EKG that we started with. Like I said, just looking at this, you can say, great, it looks normal, but let's do that a little bit more intelligently. So we can see the rate. There's 11 QRS segments that happen in 10 seconds. So 11 times 10 equals 66. So we've got a rate of 66. Rhythm, we see uniform P waves before every QRS complex with an uprate P wave in lead 1 and 2, and a consistent PR interval with uniform R to R intervals. So we're going to say this is a sinus rhythm. We look at access, as we said earlier, we can see it's up in 1 and AVL. Both my thumbs are up, so we say that's a normal access. So intervals are calculated at the top, but visually we can see the PR interval is less than 5 small boxes, the QRS is less than 3 small boxes, and a QTC being much less than half of the R to R interval. I don't see any hypertrophy that's present because I don't see a tall P wave in lead 2 being greater than 2.5 millimeters, representing left atrial hypertrophy. I don't see a biphasic P wave in V1 with a second downgoing deflection being greater than 1 millimeter. I see no tall R wave in V1 being greater than 7 millimeters, and I don't see anything even remotely looking close to the Sokolow-Lyon criteria, representing no right ventricular hypertrophy and no left ventricular hypertrophy. I don't see any signs of ischemia, meaning I don't see any T wave changes. They're upright everywhere they should be. The T waves are inverted in AVR and V1, but as we said earlier, those are right-sided leads, so they're supposed to be downgoing. And that's quickly how you put together an EKG.
Rate is 120. Rhythm is sinus. Axis is left. Interval shows a normal PR and QT, but a wide QRS. The wide QRS also has a slurred up stroke in V6. This represents a left bundle branch block. No hypertrophy is noted. There is ST segment elevation and T wave inversions that attributed to the left bundle branch block.